All right, welcome back. So we're picking back up at the two different measures of disease frequency. Now, these different measures are expressed as proportions. So the number of patients who experience a case versus the number of people whom could have experienced that event. In other words, the population that is being examined. Prevalence and incidence data become useful to clinicians and researchers when it is converted into rates. Rates being the number of cases divided by the corresponding number of people in the population at risk. These are expressed as cases per 10 to the nth power, or another way of saying that is 10 per 1,000. That's probably the most common way that you'll see things presented within an article, that there were 15 injuries per 10,000 people. So let's explore each of the subcategories underneath prevalence and incidence. Point prevalence is a measure at a single point in time for each person. So here's an example of point prevalence. What we have here is 10 patients within a sample of 200 residents or 200 patients in a skilled nursing home. And what we're trying to figure out here is what is the point prevalence of residents impaired by a stroke in June of that year. So we know that 190 aren't impaired by stroke. But what we see here, there are 10 patients represented by that circle, by that dot, who experienced a stroke, and the dot corresponds with the month that they experienced the stroke. And then we want to know how many of them are impaired by stroke in June. So we go down, we take a look, we can count up 1, 2, 3, 4, 5, 6, 7. Now, we also have to take into account the X's. The X's are individuals who passed away. So we no longer have a sample of 200, we have a sample of 198 because 2 of those individuals had passed away. So we see that there are 7 people out of 198 impaired by stroke. So that gives us a percentage of 3.5%, or 3.54 residents out of 100 are impaired or experiencing impairments due to a stroke. Period prevalence is the proportion of a population that has the condition at some time during a given period of time. It includes people who already have the condition at the start of the period and those who acquire or develop it during the period. This is almost like a combination of prevalence and incidence. We'll explore incidence here in just a moment. So for example, during a 1-year period of time, there were 20 pre-existing and 15 new cases of meningitis in a population. So there were 35 cases out of 30,000 people in that population. We can do the math. We can then see that there were that particular proportion. We multiply that by 10,000, and it then gives us an answer of 11.67 cases per 10,000 people. Throwing one more in here. Lifetime prevalence, you might see this. What's the lifetime prevalence of experiencing low back pain? Total number of persons known to have had the disease or injury for at least some part of their lives. Kind of a classic thing that gets thrown around in orthopedic literature or low back pain literature, that 80% of people will experience an episode of back pain in their life. Different things can have an impact upon prevalence. The severity of the illness, if many people develop the disease, go on to die within a short period of time, the prevalence may be decreased. It's hard to count people if they pass on before you can count them. The duration of an illness, so if the disease again lasts for a short period of time, the prevalence is going to be lower than if it lasts for a longer period of time. It all gets into how you can capture, how you can count the population. The number of new cases. If many people develop the disease, its prevalence is higher than if a few people do so. Here's a nice little picture illustrating factors that can influence prevalence. And looking at movement of people, for example, movement of people in and out of an area, depending upon those individuals, if they have the cases, if they're healthy, or if they're susceptible, may increase or decrease the prevalence. How about looking at something like improved diagnostic facilities or diagnostic capabilities? I think we've seen that over time when it comes to autism or autism spectrum disorder. That's one of the suggestions people have made why we see an increasing overall rate. That people are doing a better job of recognizing it or diagnosing it. Now, prevalence studies can be influenced by many factors unrelated to the cause of the disease. Thus, prevalence studies do not provide strong evidence of causality. Prevalence studies are helpful in assessing the need for preventative action or planning health services. So, here's an example looking at the prevalence of patellar tendinopathy, also known as jumper's knee, and one study by Leon et al. Found that the prevalence was over 30%, upwards of 55% in male elite level basketball players. So what does a study like this tell us? It highlights there is a problem of patellar tendinopathy. It highlights in that study that it can be a persistent problem, and it may not cause time loss from sport, because as they were talking in the article, people continued to compete, but it may impact performance, and jumper's knee may cause some athletes to retire prematurely. But it doesn't tell us what the causes are or what the risk factors are. It just highlights that there is a problem. So it makes us aware that there's a problem and that there may be needs for services to try to address that problem. Here is a study that I led looking at self-reported musculoskeletal pain in Latino vineyard workers. And very basic prevalence study. We went out to the vineyards as part of a group of providers providing services. So there's a group here in the Oregon area that partners with the vineyards to provide healthcare services to integrate individuals who are migrant farm workers into those services. So it's a nice collaboration between the public health nurses and the vineyards. We got to participate for a while, and so we just did basic counts. And we were looking at the percentages of people based upon who they were. For example, male vineyard workers reported musculoskeletal symptoms in the back, including the thoracic and lumbar spine. There was a total count of 82, but this equaled out to or equated to 32% of the total population. So we can see that approximately 33% of individuals were experiencing musculoskeletal symptoms at the time that they were interviewed. Could we track people from the start of the season? Well, we could. What we did is we collected at the point in time that we met with them. But if we started at the start of the season, we could identify if people were experiencing symptoms or not. Maybe that would be a period prevalence study, or if everybody was free from disease or free from injury in this case, we would be able to then maybe do an incidence study. Also, if we were able to find people at the start of the season and we did an incidence study, we would be able to determine when the musculoskeletal symptoms started. Are there certain activities, certain job tasks that increase their pain? And can we calculate the number of new cases that occur? Meaning, we don't necessarily know if we do a prevalence study if this is just chronic musculoskeletal pain that one is experiencing, or if it is a new case. Because if it's a chronic case, is somebody working through that because they just need to work because it's important for their economic survival? Or if somebody has acute pain, is that something that could be managed to help them get back to work and to be able to do so pain-free and to avoid it becoming chronic in nature? Another study I was involved with, looking at the prevalence of patellar tendinopathy and patellar tendon abnormality. And this was in male collegiate level basketball players. It was a prevalence study. What we did is we had people come to our lab and we then used diagnostic ultrasound. You see an example there. The diagnostic ultrasound, we were looking for those black areas, those hypoechoic areas, which are suggestive of patellar tendon abnormality. So we first asked people if they're having patellar tendon pain and palpated their tendons, but then we also wanted to see if there was an abnormality. So that gave us some good information about the proportions that we're experiencing either abnormality or tendinopathy. We also then calculated a prevalence odds ratio, and this is a way of looking at potential risk factors. Now, there really weren't any significant risk factors other than if somebody was a starter, or I should say starter status. This is what's interesting. Non-starters were actually at a greater risk or were at a greater odds of having patellar tendinopathy or patellar tendon abnormality. As you look at this line here, and we'll talk statistics in the next few weeks, we hypothesized that the non-starters would be at a lower risk. Reference value, the reference means there, that is the group that we are referencing or comparing the other group against. And so we see that the odds ratio was below 1.0. The 95% confidence interval was also below 0.10, or excuse me, below 1.0. So it was statistically significant. So starters were at a lower risk. Let's talk about incidence. Incidence is a fraction or proportion of a group of people initially free of the outcome of interest that develops the condition over a given period of time. Incidence, then, is the new cases of disease occurring in a population initially free of the disease or new outcomes, such as symptoms or complications occurring in patients with a disease who are initially free of these problems. So incidence is calculated by the number of new events in a specified period divided by the number of persons exposed to risk during this period. So what does this ultimately mean? What this means is the population that you've assembled at baseline does not have the disease, does not have the injury. And then what you attempt to do is to follow people prospectively forward in time to see who develops the injury and then to see if those individuals possessed a risk factor or factors that were different than the individuals who did not develop the disease. Now, the first measure of disease frequency under incidence that we're talking about is cumulative incidence, and this is the proportion of individuals who become diseased during a specific period of time. So, this particular example here, cumulative incidence. What is the cumulative incidence of individuals developing patellofemoral pain syndrome among high school runners in this table? Well, it's a very small population, obviously, but let's say we've got 5 runners, and let's just assume for argument's sake that this is a statistically appropriate sample size. What we see here is that over the course of their careers, 2 out of 5 individuals developed patellofemoral pain syndrome. So what is the incidence? The cumulative incidence here is 40%, or 40 per 100 runners. That's pretty easy math to do, right? Now, let's talk about incidence density. This is the rate of development of disease in a population, the instantaneous rate of development of disease in that population, and it's calculated by the number of new cases of a disease during a given period of time divided by the total person time in observation. So it's considered a more precise measure of incidence than cumulative incidence. So here's our same example. Now, same 5 runners, 2 out of 5 develop the patellofemoral pain syndrome, but we have the total time at risk out here, that period of time that they participated. So now we're going to be reporting our incidence density as a component of years at risk. So there were 2 cases out of 16.5 person years. We would add up all this time right here to give us 16.5. And then do a conversion to make it to some number like 100 or 1,000 person years, whatever you deemed was appropriate for your particular article. And here we now have, instead of it saying 2 cases per 16.5 years, something that people can kind of think about. Oh, there will be 12.1 cases for every 100 person years of observation, or person years of, in this case, participation. Participation, observation being the same thing. Does that make sense how the math would be done? Here's some commonly used rates. So depending upon what discipline you were in, if you were involved with nursing, pediatrics, medicine, you might be talking about things like mortality rates, infant mortality, perinatal, maternal. We hear about mortality rates all the time. Complication rates. Let's say you're an orthopedic physical therapist and you were doing a study looking at a new surgery. What are the different complications? What's the risk of infection with this new type of surgery? So some different examples there. Here is just a review slide of the differences between incidence and prevalence. Does it make sense to you? If it does, great. We're going to be working on exploring examples of these this coming week. If you have any challenges understanding between the prevalence and incidence, please reach out to me. All right, now looking at the design of a prevalence study. People in a population are examined for the presence of the condition of interest. Some have the condition at that point in time, others do not. So prevalence studies are also known as cross-sectional studies. These are studies conducted at a cross-section in time. So again, what are they good for? These are good for describing prevalence, and they are used sometimes for examining associations. They are fast, they are relatively cheap to do. Dropout's not a problem. You don't have to try to monitor people and follow them over a period of time because you've collected all your data at one point. If you were to do serial cross-sectional studies, they can provide trends. We'll see an example of that in a bit. And oftentimes these studies are a first step. They're an initial step towards a more rigorous study. Limitations, they cannot infer causality. You can't make statements about what preceded what, so there's no temporal order. And they're not good for rare diseases or those of brief duration. Here is an example of a cross-sectional study assessing the prevalence of steroid use among Major League Baseball players. We can see here in 1990 in this made-up situation that 5% of Major League Baseball players used steroids. Now, if you were to do a longitudinal or repeated measures at designated periods in time, you might see that that prevalence changed, that it increased. Again, these strengths are important for planning health services. Provide valuable information about what to expect in different clinical situations, and they are less time consuming and inexpensive to perform. They are, however, only weak evidence for cause and effect. Now, the incidence studies, these are also known as cohort studies. The population that is assessed is the cohort. Cohort's a group of people having something in common, and then they're followed over time for the development of the outcome events. So my examples from my research, my cohorts are Division III athletes. They start the season injury-free, and then I follow them over the course of the season for time loss injury. Other examples, individuals who are cancer-free until the onset or not of cancer. So you'll see studies sometimes that will be a 10-year time period. What was the risk of developing cancer over 10 years? What was the risk of developing heart disease or cardiovascular disease over 10 years? Very common things. All individuals may have recently been diagnosed with a disease and then followed forward in time for outcomes. So another type of incidence type of study is maybe everybody isn't healthy at the start. Maybe everybody has the disease, and then now you're following them forward in time and looking for increases in death. So if everybody had, let's say, cancer, what increased their risk of mortality? Or maybe they had the disease, they were treated, and then followed forward for recurrence. What increased that risk of recurrence or not? Recurrence might be one of those things where if you've got a diseased population, was it because they didn't stop smoking? Was it because they did not change their diet or they did not continue an exercise program? Maybe you've heard of the Framingham Heart Study. This is something that's been going on for generations, and it is one of those studies where they have published thousands and thousands of papers looking at, and doing so prospectively, looking at heart disease. You can imagine that to tackle something of such magnitude, don't think in your time at Rocky Mountain University you're going to be able to do a prospective cohort study to determine risk factors of a particular major disease. These require significant amounts of time, of professionals doing the work, and dollars, grant support dollars, or just, overall investment in infrastructure well beyond what any of us could do at this point in time. But it's just kind of a fascinating thing, and I like to highlight this example because it's studies like these that continue over time, that continue to improve our knowledge about heart health. Now, with a cohort study or an incidence study, there are strengths and weaknesses. You are able to appreciate the temporal sequence. So, did exposure precede the outcome? And what we're talking about here is, did somebody develop a risk factor or have a risk factor and go on to develop that disease or injury? You're able to calculate incidence rates, and you're able to study rare exposures. You may have to follow large populations for a long period of time. That would be a weakness. These studies can be expensive or time-consuming. That would be a weakness. They're not good for rare diseases. Why do I say that? Well, let's say you have the ability to monitor 50,000 people. But what if the disease only occurs in every 300,000 people, and you've got the wrong 50,000 that you're following? And loss to follow-up can introduce bias. So how long you have to follow somebody for, that could be problematic. We're nearing the end here. One thing I want to highlight for you and bookmark for the coming weeks is OpenEpi. OpenEpi is free statistical software related to epidemiologic research. Readings from this week, there is the Marin and the Guthrie articles. There's going to be a discussion that is due, and you're going to identify opportunities for prevalence and incidence studies in your current employment position. Now, if you're in an employment position where you're able to work with individuals clinically, great. Sometimes people are working in academic environments and maybe don't have access to patients. Then what I want you to do is imagine your population that you would most likely be working with if you were working exclusively in clinical practice. Now, please describe one potential study for prevalence and one potential study for incidence. Include the following in your discussion: things like tools or equipment you would need to collect measures and the rationale for each measure. In addition, you'll discuss the potential viability of each study based upon your current employment position. Here's some examples. Prevalence study. I might look at the prevalence of male collegiate basketball players with patellar tendinosis at the start of the season. The tools and equipment I would need would be a diagnostic ultrasound and a Visa P. This is something that I could do because I work in a Division III college and have relationships with other athletic trainers at other universities. An incidence study could be the incidence of construction workers who develop low back pain on the job during the year. What would I need? Access to human resource documentation, so looking at injury reports. Could also benefit by accessing medical records. How potentially viable is that study for me? It is not something that I would have an easy time being able to do since I am not working in those areas. So this week you have a week 2 homework. It's worth 10 points. And then the discussion's worth 1 point. The purpose of the discussion is to start to get you thinking about what you could do as your research project for this term. Not research study, but a research project where you're trying to develop an epidemiologic study. All right, have a great week. I'll be on daily or every other day to check forums and to provide feedback and answer questions. And again, please email me if you have any questions. Now, talking about the projects. The presentation, it's worth 10 points. Each of you will provide up to a 10-minute presentation. Create a screencast with a PowerPoint. Don't just use your poster. Have it be similar to the example I give this week. Now, this presentation, you're going to describe a potential epidemiological research project. Presentations will be evaluated for completeness and consistency of proposed measures and variables with the study design. So you're going to see what I prepared for Screencast 2, the supplemental screencast. And what I'm looking for, your presentation should include an introduction section, a methods, and a statistical analysis section. So what statistics you will use. So here is the breakdown. You've got an inclusion of hypothesis, describing the purpose of your research study, present your dependent and independent variables, identify the instruments or measures you'll be using to collect data, and the clarity of your communication. Your poster, 10 points, will also be turned in at the same time. You will create a poster that corresponds with your presentation. Now, this is not an actual 4-foot by 4-foot poster that you would do at a conference. Rather, you're going to create a poster using the poster template found on Canvas or any template of your choosing. There are some poster examples presented in this week's modules. Poster rubric for that assignment, title section, author's name and affiliation, 1 point. Your thoroughness and completeness of your introduction section, methods, statistical analysis, and use of figures and tables, and your reference section. Now, as you look at your poster examples, don't make your posters just a dump of words. It is perfectly fine to have a nice layout with text and mini figures or tables. And I say mini like M-A-N-Y, mini, not M-I-N-I. You want to have your poster that is catching the eye of the passerby so that they stop and look at things and create a dialogue with you. If you just put all text, more than likely, people are going to walk on by and not have an interest in it.